Welcome to this webinar on working with clients with challenging trauma. I'm Sally Guy. I'm the Director of Policy here at the Canadian Association of Social Workers, and I'm really excited to be moderating this event. So before I actually introduce our speaker, some housekeeping details. So information like what to do if your screen is freezing, how to get your certificate of attendance, where to download your slide deck, all that stuff, that's written down in the welcome widget. It should have popped up when you first logged in. If it didn't, you can access that and other widgets by clicking those sort of colorful icons at the bottom of your screen. And just so you know, you can customize your screen. You can make any of these windows smaller or bigger by dragging them, just like you would with like a Word document. So there's also about 500 people signed up for this event, so I would encourage you to type in your questions as soon as you think of them. We're going to do our best to get to lots of them during the Q&A section at the end. So with that, I would like to introduce our speaker, Dr. Robert T. Muller. So Dr. Robert T. Muller is a professor of clinical psychology at York University. He also practices with adults, children and families in Toronto. He's also an award-winning author, and his work all focuses on trauma. He's lectured all over the world. He also founded an online magazine called the Trauma and Mental Health Report. And I would encourage you to get to know him fully by reading his bio under his picture, which is on the right hand, maybe this side of your screen. Suffice to say, though, we are very lucky to have him with us today to share his expertise. And with that said, it's my great pleasure to pass it over to you, Rob.
Thanks so much, Sally. Okay, so the talk that I'll be speaking about today is about it's an introduction to trauma, and it focuses a lot on this idea of helping trauma clients to open up. And I'm going to just advance the slides, and Sally will let me know if there's any problem with visualizing them there. The material that I'll be speaking about is primarily today based on what I've written about in my new book, Trauma and the Struggle to Open Up, From Avoidance to Recovery and Growth. And I'll occasionally refer to different sections from the book as I'm talking today. Okay, so what is trauma therapy? Well, I argue in the book that ultimately it is a path to help people open up. What that looks like, what opening up looks like, will be different for different people. For some, it's opening up about the trauma itself, specifics around their actual traumatic experiences. But for others, it's opening up to life, to relationships, to experiences, because trauma shuts people down. Opening up to their own bodies, because trauma cuts people off from their own somatic experiences and to their own histories. Trauma therapy is a phase-based approach. It's really important that we be aware of some of the earlier work in trauma when we are looking at newer works on trauma. And Judith Herman's Trauma and Recovery beautifully encapsulates the 3 phases of trauma treatment: safety, remembrance and mourning, and reconnection. I won't go into huge detail on this, but I will say that it's really important that trauma therapy be paced, that the process be one in which we don't try to help the person bite off more than they can chew. Opening up is a slow process, and trauma therapy can't be rushed. When people come into therapy and they just simply tell their story too quickly, what happens sometimes is it leads to feelings of humiliation. And that's what I worry about when I see people who come in and tell their story too quickly. They feel like, oh my God, I've spilled the beans. And then they don't come back for a second session. And so that's ultimately, it may be cathartic in the moment, but it's just transient, and that's not therapy. So we have to be very thoughtful about pacing. So as would be implied from the idea of opening up, why do people need to open up? Well, because so much of the time when people have trauma histories, they de facto learn to stay silent. And staying silent about the trauma is problematic in many ways. Now, of course, I'm not saying people need to rush in, of course, as I've been saying all along, and tell their story. But what happens is when people have been carrying around a secret, it's quite burdensome. Then why do people carry around these secrets? Well, for good reason. Secrecy can be protective. Secrecy from one's own trauma story can be protective from the truth, because the truth can be dangerous, right? It can be protective of relationships. If you have a relationship with a parent or a close friend, and trauma has occurred in that relationship, then sometimes people want to protect the relationship, so they deny the truth. Secrecy can also protect one's image to outsiders, and it also protects the status quo. So secrecy can actually be quite protective. Why else do people stay silent about the trauma? Well, because of loyalty. Loyalty to one's family and to one's institution. These are all very, very profoundly strong attachment bonds that we feel when we feel loyalty to one's family. And loyalty can suppress one's trauma story. Again, we keep it secret very often because we want to somehow protect the relationship with people who we know should be close to us, but with whom we have felt such pain and hurt. In the military, we also see this loyalty actually with something called military sexual trauma, where we see a high level of group loyalty and secrecy about sexual abuse. Okay, I was going to give an example of that, but I'm just thinking in the interest of time, I really want to make sure we get to questions. So I'm going to just move forward a little bit. Why else do survivors stay silent about the trauma? Well, they will suppress their own trauma stories very often. And when we talk about suppressing one's own trauma story, we see examples of self-deception, where people will use rationalization as a defense. So they'll cope with the reality of their story by rationalizing it. I'm sure we've all seen clients who perhaps have had physical abuse histories or have had severe corporal punishment, and they'll say things like, well, back then all parents hit their kids. They'll also intellectualize, where they will cut off the emotional meaning of a traumatic event and just speak about it in factual, detached kind of ways. They will avoid trauma memories. So, quote, forget about it, and use dissociation, where they will literally cut themselves off of their own experiences. And sometimes it's interesting when we see cutoff of affect, where people will neutralize memories. So what is this? What am I talking about here? Here I'm talking about the example where the person might say to you in very flat, factual ways, my father once threatened me with a knife. Yeah. And then, a couple weeks later, such and such happened, and then they'll talk about it. But what they're doing is they're remembering the story, but they're remembering the story where they're cutting off the emotional memory of the story. So cutting off affect, that will neutralize memories. So when we talk about memory of trauma, it's very complex. Sometimes people will actually suppress memories. More often than not, what they will suppress is not the factual information per se, but rather the meaning or the affect associated with the factual information. So, my dad, one time my dad punched me in the head. I had to go to the hospital for an MRI. Right. No, I wasn't abused. No, I wouldn't say that. So you might get someone saying, and I've definitely seen many clients who have that paradoxical reaction where the memory of the facts are there, but the emotional meaning is cut off. So all of these are examples of people suppressing their own trauma story. These are ways that people stay silent about the trauma. Okay, let's take a look at an example. This is the case of Annette. And I talk about this in the book. I think this is in chapter 3. I believe it's in chapter 3. And in Trauma and the Struggle to Open Up. Okay, so here's Annette, and I'll just read a little clip from Annette's from Annette's memory. So Annette was asked if she can recall any examples. So I asked her about her childhood history, and she was, and I gave her the adult attachment interview. And in the adult attachment interview, we asked people for various kinds of memories of their relationships with each of their caregivers. And so here she was talking about her relationship with her mother, and this story comes up. So just listen, and we'll unpack this a little bit. So she says, I remember when she left. She took her luggage and her fancy pink cosmetics case and told us, I'm just leaving for a few weeks. My clients need me. And I said, sure, I'll see you later. And it was just me and my little sister at home. My sister shouted, no, don't, Mommy, come back. And I'm like, hey, just take it easy. She's only going for a few weeks. She'll be back. Don't worry about it. Later on, when my dad came home, he got angry. He was shouting at us for letting her leave. He told us we shouldn't have let her. And I was like, no, don't be crazy. She just left for a few weeks, and she'll be back. She goes all the time. There's nothing to make a big issue of. I mean, it was true. She would leave for a few weeks all the time and come back. It was fine. I mean, we really were quite fine with that. But my dad was really upset. And me and him couldn't get along at first because he was like, what's wrong with you? Don't you realize what's going on? And I was like, you don't know what's going on either. Don't worry for no good reason. But then a year went by, and then it was another year, and then another. And it was just so much time. And she didn't answer any of my letters. It was just so much time. So much waiting. I don't think she's ever coming back. Okay, let's unpack that a little bit. Any reactions? I'm going to open that up to audience members. What are some of the things you notice? Think about affect. Think about coping. Think about some of the themes I've been talking about. I think Sally might read some of these reactions out. Go ahead, Sally, if there's anybody who's typed anything in just yet. Oh, I can't hear you, Sally. You can hear me, right?
Yes, I can. Yeah, no, I muted myself so no one would hear me breathing.
Okay.
I have someone commenting that this sounds just like a denial of acute feelings. So I imagine sort of like that, a year goes by and then another year goes by and having to come to terms with that.
Nice.
I have another one.
So hang on. So let me just respond to that briefly. So denial, very good. That is an important coping mechanism. And that's fundamental to the kind of thing we're seeing here when people cut off their own story, their own trauma story. So denial, and it's very good. What that listener pointed out was denial of affect, denial of feelings. Mm-hmm. So, and that's fundamental here. Good. What else?
We have coping strategies, downplaying the situation.
Okay, nice, exactly. So what John Bowlby, the parent or father, let's say, of attachment theory, would say is that this is an example of minimization. So minimization is the reduction, taking a story and minimizing its impact. And by doing that, what we do essentially is we are able to cope with its reality. But of course, at the end of the day, it takes us out of the reality of the feeling and turns it into something else, doesn't it? Okay, anything here? Any other reactions?
I mean, we've had about 50 come in, and they're all super interesting. I mean, Annette focusing very strongly on her dad's feelings instead of her own, the contrast between the siblings' reactions as well as hers.
Okay, let me just
and then a lot of repetition.
Good. Okay. Nice, you guys. So, focusing on dad's reaction rather than our own. So that's another thing. It's taking, as if it's disavowing one's own feelings. My dad was angry, I wasn't, kind of thing. And whatever feelings she had then get undealt with. They get to be seen as just dad's feelings rather than her feelings. Nice observation of the siblings as well. This is also something we see in trauma homes, homes where there's a trauma history. Sometimes there's one sibling who's a feeler, kind of a super feeler, and another one who cuts off feelings. And they might talk about the same event in completely different ways, as if they were, as if they weren't both there at the same event. And so she describes her sibling in a way that minimizes, like says, my sister was crazy, or I don't remember if she said her father was. She's referring to people who have feelings about what happened as crazy. Okay, good, very good. All right, so let's move forward. So these are just some. This is just a nice example of what I'm talking about. I'm going to skip forward just in the interest of time. All of what I'm talking about there is in the book in chapters 3 and 4. Okay, so just in the interest of time, folks, I'm moving forward a bit. So, all right, so we've talked about avoidance. What about those survivors who rush in, right? So here's another thing that we see in trauma. When we see trauma disclosures, we sometimes see people dealing with it from a coping perspective in the same sort of way as Annette does. We also see people who do the opposite, who will rush in and will try to just, in a kind of a verbal diarrhea kind of way. First session, they will tell you, I have a trauma history, and boom, they will just go into it, and they're traveling within seconds, and you're thinking, oh my gosh, how did we get so far into it so quickly? I've known this person for 7 minutes, and he's going into all the gory details. So this is a tricky and important thing in trauma therapy. Why do we see this? Well, we see this because of the following. Trauma stories are a burden. The secret is a burden, and people have fantasies, and the fantasy is telling will fix everything. We have fantasies that relate to, the catharsis idea. And again, there's nothing. I'm not as against catharsis as a lot of people are. I do actually think that sometimes we need a good cry. Sometimes we need we need to feel intensely, and that's okay. There's nothing wrong with that. It's just about different people have different needs at different times, and we want to be aware that many trauma survivors will think what they need to do is just blurt the whole story out. And where I worry is with those people who blurt everything out and then they feel shame and humiliation afterwards. And with those particular clients, it's tricky because then those people will sometimes end up not coming back to therapy for years. So we need to be mindful. And I think the safest thing to do, as I pointed out in the slide before, is pacing. Pacing is critical. So we want to be very aware of that. We want to be aware of how to pace the process of opening up. As I pointed out, too much too soon can be overwhelming, humiliating. The therapeutic relationship just isn't ready for it. And that's another thing that I focus on in trauma and the struggle to open up, is not just safety from the standpoint of using grounding strategies, although those are very important. If you do trauma work, helping people use grounding strategies and to use relaxation. But not just that, but also safety in the therapeutic relationship. We have to establish safety in the therapeutic relationship. And I focus on that in great detail in the book in chapter 5. So safety in the but I'll talk about a little bit of it right here, right now. So safety in the therapeutic relationship, in part, is is reflected when we pace the process of opening up. And when we look at it and say, hey, is the therapeutic relationship ready for this much disclosure just yet? And so how do we help people gently apply the brakes without having them feel like you're saying, shut up? You know, you've been holding this secret in for so long. I'm not ready to have you tell me this. Shut down. Well, we don't want people to feel that. Finally, I have a therapist in front of me who it looks nice enough, like they're willing to listen, and he's telling me I should shut up. I feel like a total loser. Okay, so we don't want that to happen. We want to help people feel like we're respectfully and gently helping them apply the brakes so that they can disclose at a pace that feels safe relative to the therapeutic relationship. This takes some skill. Okay, this is not an easy thing to do, but it's very important. Okay, so what am I talking about here? How does this look? How do we do this? Well, let's take a look at the concept of containment. Containment is a very important psychotherapy concept. I didn't invent the idea, but containment is what we want to do first. So what is containment? Well, in containment is a therapy relationship idea. And in containment, what we have is some confidence in the therapy relationship. Is this a holding environment? Is this an environment where I will feel held by the therapist? When we think of holding, Donald Winnicott's concept of the holding environment. Donald Winnicott was a pediatrician and psychoanalytic, and he was very much thinking about the parent holding the young child and how critical that is to normal development very early on. He, of course, was talking both about physical holding. After all, he was a pediatrician, but he was also a psychoanalyst. So he was talking about the physical holding, touch, and providing safety through physical holding, so critical to normal, healthy development, but also psychological and emotional holding, which it becomes a metaphor as the child grows up, and you provide a psychologically containing environment. So what does that look like in trauma? Well, confidence that the therapist can hold my trauma. When we feel contained by our trauma therapist, when we're clients in trauma therapy, when we feel contained, we feel a sense of confidence that my trauma will not overwhelm my therapist, that I will be able to say the story and he or she is not going to freak out, right? And not to say that you're doing anything to make the client worry about that, but clients will worry about that all on their own because they've told people in the past and they have freaked out. They've gone to their friend. They've gone to the non-offending caregiver. They've gone to their sibling and said, hey, dad did this. And the sibling said, you're crazy. And then they said, the response, of course, my older sibling's telling me, am I crazy? I must be crazy. I must have invented that. And that's what people do. That is what happens in trauma, right? The therapist, of course, is not going to, but the fear is, might the therapist do that? After all, this client doesn't know you. You might do that. You might call them crazy. They don't know what you're going to do, right? So, is the trauma going to overwhelm or cause you to, is the trauma going to be too powerful? All of these things are things that clients will worry about. Containment also reflects the idea of confidence that the therapist can hold the client, again, emotionally, metaphorically. If I push you away, the client might wonder unconsciously. These are unconscious ideas. If I push you away, why would I push you away? I might push you away, therapist, because I'd rather push you away than worry you're going to push me away. So this is all going on unconsciously. If I push you away, will you abandon me, right? So that's a fear that trauma clients have. Again, why would they think this way? Because they've had so much abandonment. They have been abandoned. If they haven't been abandoned physically, they've been abandoned emotionally and psychologically. Will you punish me if I push limits? Will you give in if I cross boundaries? If I act in a certain way that pushes boundaries, will you somehow give in? If I want to be your friend, will you become my friend, my buddy, and go for coffee with me? those are things that we don't want to have happen in trauma therapy because it feels unsafe. We want the client to feel that boundaries are going to be respected in a gentle way, but in a clear way. Not in a brutal kind of critical way. I'm going to hold boundaries in a rigid way, but in a thoughtful, caring, loving way, the way a good parent holds boundaries in a safe way. So all of these things are critical to containment. And that's a critical idea when we think about helping pace the process of opening up. So you'll see how that concept, I wanted to convey the concept of containment, how that might look in the process. Okay, so let's move forward. So when clients rush into trauma story, we want to provide containment first. First, let's look at a case. This is the case of the Canadian pilot. Now, this is a gentleman who so this is on page, let me find this. Give me a moment. It's somewhere here. Okay. Yeah, okay, here it is. All right, so I'm on page 60 in Trauma and the Struggle to Open Up. And this is a fellow who I saw many years ago for therapy. So, all right, I'll read this piece to you. Where am I? Am I on track? I'm on track. Good. Excellent. All right. Providing containment in the therapeutic relationship. A few years ago, I worked with a Canadian pilot in therapy. He had been referred to me because his wife's psychiatrist was worried. In her therapy sessions, the wife had been complaining about her husband's prescription drug abuse and unpredictable rages. In addition, there was a lack of sexual intimacy in their marriage for the past several months. Also concerning because it was out of character for him. The pilot was now regularly invoking God into their discussions. One day, he emailed his wife 4 words: "I want to separate." His wife, thoroughly practical, recognized how odd this all was and was more concerned for his mental health than anything. She told me that her husband had lost 6 of his closest friends in a recent helicopter accident in Afghanistan. Now stationed in Toronto, although he was supposed to be participating in a local training program, he was calling in sick and staying home in bed, seemingly depressed, highly agitated, and he'd even lost interest in seeing his teenage daughter from his previous marriage. This was all unlike him. I worked with the pilot for about 8 months before he was stationed elsewhere, but in our very first session, as we discussed an unrelated topic, he blurted out that he was sexually abused at age 9. He'd been forced to perform fellatio on his male babysitter. This he followed with a question: "Is that why I'm so fucked up?" I told him that, frankly, I didn't know. I didn't know him just yet, so I really couldn't say. But that I'd try to help him figure it out. And about 2 months into our work together, we did start to unpack what had happened with the babysitter, what he felt about it, what he worried it said about him. But at that earlier point in our work together, I was just trying to forge a connection. This fellow was someone who, I came to realize, had never talked about his sexual abuse with anyone. Other than his high school girlfriend, he'd never shared his secret with friends, nor family, nor with his concerned wife. Okay, so let's think about that a little bit. Let's use that a bit as a way of thinking about how to slow the process down. So the first piece about slowing, or you know what, actually we have a couple minutes before I'm just looking at the timing. Let me ask people, I'm going to actually backtrack by 1 slide, and I'm going to ask people if they have any initial thoughts as they hear about that case? What are some of the things that you notice? Anything you want to point out? I like to sometimes bring in some audience participation during the talk. I think it can enliven things a little bit. Any thoughts about the Canadian pilot from what you've heard just so far?
So I have someone that just typed in, it must have been so hard for you not to say, but you aren't fucked up. I'm wondering if you could unpack your decision to not address that.
Good. So that's a great question. So I'll get into what I did say as an alternative, but I will also put this out there, that with trauma clients, I do sometimes use reassurance. I do think that it is okay to use reassurance. I'm not against using reassurance with people. Sometimes people worry tremendously about what the trauma says about them. And they also worry that I think the worst about them. So sometimes I do that. It depends a little bit on what you see and the person's level of general coping. This happened to be a person, this pilot happened to be a person who in general had very good ego strength. Now, at this moment in his life, he was not functioning, right? He was depressed. He was not going to work. He was dysfunctional. So yes, he was struggling, but this was also someone who, when he was functioning, could function at an extremely high level. So I want to be judicious about how much reassurance I use. The reality is, in his experience, here is a guy who is normally functioning so well, and right now, as far as he's concerned, he is just fucked up. And so his question is why I'm so fucked up. If I say you're not fucked up, I worry that it would feel like false reassurance to him. That's what my worry would be. And I didn't really know what the meaning of his question was, what was behind it. And so that's why I said, so I try as much as possible to resist the temptation to only jump to reassurance. But again, as I say that, I'm not against reassurance. I do think sometimes it's helpful. We just want to be thoughtful about balancing reassurance. I think sometimes that's okay, balancing it with unpacking what the person's worst fear is. So you might say, as I hear you talking, Joe, let's say as I hear you talking, Joe, I'm thinking about how fucked up you're feeling. And on one hand, I know you've been sitting with this story for so long. There's a part of me that knows that of course you can cope with it. You have coped with it. And to that extent, no, you're not fucked up. You've been a pilot for many years, despite the fact that you've had this really terrible history. On the other hand, I'm also hearing you say that right now you're not feeling like you're coping in a normal way. And so that feels so fucked up to you. And so I might say something like that, something that kind of provides a little bit of an empathic space to explore both sides. I hope that answers the question. All right, now I do need to move forward, so I'm going to do that. All right, so let's talk about slowing the process of opening up. How do I respond to that sort of thing? Well, first, I'm just going to give a couple different conceptual pieces that you can use to hang your hat on and that you can use here. So containment. When we talk about containment, the overarching idea is slowing the process of the disclosure down. It's a respectful slowing down. It's a loving kind of slowing down where you respect that the person's there for a very good reason, that they really have an important story to tell. But it's also saying, hey, too much too soon can overwhelm you, and so we want to do this at a pace that works okay. And I actually say that to people so that if they wonder, sometimes I say, part of what we do when we think about doing work around trauma is pacing the process. So I say that to people. I say it so that they know what I'm thinking. Otherwise, they're wondering, what are you thinking? But so what I do here around slowing the process down, the first piece around when people come in with blurting out trauma disclosures is honor the telling. So what do I mean by honor the telling? Honor the telling refers to refocusing from the telling of the details to the idea that here the person is telling a story. So the person comes in and tells me, like the pilot tells me, and then this happened with my babysitter, and as soon as he comes up for air, I might say, okay, Joe, I heard you tell me a little bit about kind of what happened with your babysitter when you were 9 years old. I think, you mentioned earlier on about your wife who thinks that, what happened with your buddies in Afghanistan is a really big problem. And I understand you think it's a problem too. Let me ask you a question, Joe. Is this the first time you've ever shared the story about the babysitter with anybody? Or have you talked about it before? So when I ask that question, what I'm doing is I'm doing a rhetorical shift. I'm shifting the conversation. It's kind of what politicians do when they change the conversation, but here I'm doing it for good reasons rather than for nefarious ones. The person, if you stick with the trauma details at that early point when the therapeutic relationship is not yet ready, the person will feel overwhelmed. And so when you shift away from that to just not 180 degrees, you don't change the subject, say, oh, so tell me about something, else completely. No. Honoring the telling is a slight shift. It's a shift from the trauma details to the idea of the sharing of the story. So a question that I like to ask, is this the first time, and Joe says, oh, yeah, I've never talked. Oh, you've never talked. What's that been like, holding in a story for your whole life? Has that been hard? So again, we're talking about the telling of a story. What does it mean to you, having shared the story with me? I noticed, Joe, you and I don't know each other very well. We've really only known each other for about 10 minutes. What's it like having shared the secret? And Joe says, you know what, it's really weird. And I can say to him, it sounds like it's a bit weird. What's the weirdest thing about it? So we're talking about not the trauma details. We're talking about the sharing and the telling of the story. Having shared this, what are you feeling right now? The person might say, you know what? I can tell you, you might think I'd feel weird about it, but I don't. I feel fantastic. So I might say to them, okay, sometimes when people unload a burden, they do feel relieved. But I want you to do something for me, Joe. This week, if you feel anything else, like if you feel a little weird about it, or if you feel, I don't know, anything that feels in the slightest way vulnerable or uncomfortable, write it down. And then next week, we can talk about what some of those things are. Why do I do that? Because it's a containment exercise. It's active. It says you can do something with these vulnerable feelings, and I'll be with you, and we'll explore it next week. And it's a containment thing. That's honoring the telling. I'll move forward with that. Also, part of honoring the telling is conveying an awareness of the story's magnitude. I might say something like, Joe, as you told me about that story, I imagine the story has had a big impact on you. And let's say he goes back, he says, yeah, well, it certainly feels kind of like, listen, let me tell you this, doctor, I would never tell anybody, any of my buddies that I work with, about any of what I just told you. And I could say to him, because what would be the hardest part about telling anybody? I'm actually not saying that you should tell anybody, but I hear what you're saying, but I'm curious, what would be the most upsetting thing about that as you imagine that? Well, I mean, like I just, they would think that I'm totally screwed up. And I'd say, okay. So yeah, as I hear you saying that, it sounds like you feel the story has had a big impact on you. And I'm thinking back to what you said earlier when you said to me, Joe, is this why I'm so fucked up? That you're thinking that this story has had such an impact that it's kind of fucked you up. So that's a very powerful story. So again, it's about the telling of the story that we're focusing on. Conveying my sense of, this is an important story you told me. What does it mean to you having shared this with me? So I've got some other things in there around honoring the telling. All right, let me move forward a little bit, but that's honoring the telling. That's the first piece. The second piece in this process of slowing, on this theme of slowing the process of disclosure down, is flagging the topic for therapy. Unpacking the story All right. So what I mean here is, I might say so we've honored the telling. I might say something like, and I'm thinking about now some of what you told me, because you told me something about how your parents weren't home and the babysitter was, would always, wait until the car left the driveway, and then you would feel scared. I'm thinking about how unpacking some of the details of the story might be part of our work together. Right now, I'm thinking that going into all those details might feel a bit overwhelming, but I'm thinking also that later, as we continue to work together, we're going to explore some of these details together. What do you think about that? So what I'm doing there is I'm saying, and it may seem obvious to us, but to the client, it's not obvious. To the client, it's not clear. If I'm not interested in the story, am I shutting it down forever? Maybe. They don't know. And so what I'm saying is, I'm providing some containment. I'm saying, let's engage the low burner. The story is simmering, but it's not at a rolling boil just yet. It's not to say it won't be, but it's not at a rolling boil just yet. So all of that, by flagging it as a topic for therapy, it says this is something that we will explore. It'll be part of our work together, right? So I'm not abandoning you. It's part of our work together. And then this piece is important. Don't just let weeks and weeks pass and don't bring it up again. This is a really important piece. Trauma therapists supervisees make this mistake so often. They say, well, the client said something about how she was raped in the first session. We've been working together 2 months, but she hasn't brought it up since, so I don't know. And I say to supervisees, if she brought it up at all, it's in the room. It's in the room. It's fair game. If the person brought it into the room, it's in the room. Don't make them go through the excruciating process of once again having to broach the topic. They've broached it. They said, I was raped when I was in university. If you can find ways to connect to that topic, you can grease the wheels and help them. Not by forcing the issue on them, just by inviting it along, by greasing the wheels. So what I say is, for example, for the client who's 2 months have gone by, I might say, it's interesting. I'm hearing you, Judith, I'm hearing you talk about, this coworker who, the person who you're working with at the, I don't know, let's just at the auto body shop, and how she was telling you about her boyfriend beating her up, and that you start to cry and you don't even understand what happened. I'm thinking back to our first session where you told me that you had been raped or sexually assaulted in university. What are your thoughts about that? I mean, I'm wondering if there's some connection. Now, that's a fine way of asking it. Now, the person I don't know what the person's going to say. She might say, no, this is totally different. That was in university. This was when she blah, blah, blah. And so I'm saying, okay, so the client is a little bit, defensive about it, and that's okay. And so maybe she's, struggling with the issue. But more often than not, what I see clients say is something like, yeah, I mean, I don't know. I mean, she was kind of talking about this and I was talking about that. And I might say, okay, tell me how it's different. So tell me all the ways in which the way she was talking about is like this, but then the way you're talking about is like that. And it doesn't matter. You're bringing it into the room. You're starting to let the topic breathe. And by bringing it into the room, it starts to set the stage for continually bringing it into or by giving space for it to be brought into the room, rather, when there's thematic opportunities or emotional opportunities for a connection to the topic. So let's look at how this might look with Joe. Bring it back into the room. What bringing it back into the room conveys is your topic, your trauma isn't too much for us. Your trauma isn't too much for me to handle. So let's look at how this looked with the Canadian pilot. I'm going to read you a little blurb about how bringing the topic back into the room looked like, revisiting the topic soon. With the Air Force pilot, after he divulged a history of sexual abuse by his babysitter, as I mentioned above, I honored the telling, focusing on his feelings about having shared this with me. I then flagged it as an important topic that we'll unpack together over the upcoming weeks. And then I inquired about other areas of his life. His relationship with his daughter, his feelings about his wife, his fear of messing up his military career, his new found. And then, now this is the revisiting the topic idea. And then toward the end of the session, I very briefly listed each of these as possible areas we can work on together, including the sexual abuse. So I might say something like, so Joe, you've talked a little bit about, what happened with the guys who died in Afghanistan, how hard that was. Just a little bit, you talked about that. You told me about how you're worried about your daughter and how she might have attention deficit disorder, so maybe we'll look at that. You told me a little bit about how you and your wife are fighting a lot, so that's going to be an important issue. You also told me a bit about how when you were younger, you were sexually assaulted by your babysitter. Those are all things that I think we might want to look at. What are your thoughts about that? So that's a tiny little thing. It's a tiny thing here. But in other words, I brought the disclosure back into the room. I named the sexual abuse. I didn't go into explicit details, just named it, as if to say, it's truly an issue. Here it is. I can see it, and you can see it. It's not all of your story, but it is part of your story. And together we'll address it in good time. In this way, as therapists, we can help clients slow down their disclosures. So as you can see, what I then would do is I might in a later session also bring the disclosure back into the room. He's talking about a friend of his. He's talking about his wife saying, or he's talking about a memory about his girlfriend. And I might say something to him like, I notice you've talked a little bit about your first girlfriend as opposed to your relationship with your wife. And it's interesting, Joe, as I hear you talk about how special that relationship was, you also told me that the only person you ever disclosed about the sexual abuse was your first girlfriend. And so I get the sense that there was a way in which that was a very special relationship. You even could talk about your sexual abuse with her. Is that right, or am I missing something? So again, I'm bringing the disclosure back into the room when there's a thematically appropriate opportunity for it. And by doing that, you're not forcing the issue on them. You're honoring it. You're revisiting it. You're giving space for it. You're saying, I'm interested in this topic. I'm open to it. It's not the only topic I'm interested, but I'm open to it. And it really makes it easier for people. It feels like, oh, okay, for people, oh, my therapist is not coming undone because of us talking about this. So let me finish up so we have time for questions. Remember, containment before opening up. Trauma work takes time. Pace the process. I want to make sure we have 10 minutes for questions. So I'm just briefly going to say I have an online mental health tool called the Trauma and Mental Health Report. It's an online magazine that you can use to learn about trauma and mental health, and your clients can as well. All you need to do, it's free. All you need to do is, we have new articles every week. All you need to do is Google the Trauma and Mental Health Report. It's my online magazine. I also want to point out that I have a bunch of workshops coming up. You have this list, and one is coming up very soon in Stratford, Ontario, at the end of October, where I will go into great detail about stuff we've talked about here today, and then also about using the relationship, safety in the relationship, identity, which we haven't talked about, forgiveness in therapy, and how complex an issue that can be. So all of this, all focused on trauma. So I'll be in Stratford, Ottawa, Mississauga, and then out west as well in Canada. These other ones are with Jack Hiroshi, and if you want to find out about this, go to my Google Robert T. Muller, York University, and go to the very bottom, upcoming workshops, and you'll see some of these listed. And you'll also see my email address. If any of these aren't listed, email me, and I will give you specific information. I don't mind being emailed. Please feel free. And these are my book titles. So I have 2 books, Trauma and the Struggle to Open Up, and trauma and the avoidant client. Both are available there. Okay, let's open it up to questions. I think we have about 8 minutes, or 10 minutes. Actually, it's 1:50. Good. 10 minutes. Woo! All right.
Good celebration. No, wait, this is super informative.
Okay,
I've got a good mix of questions already. Some practical, some more exploratory. I'm going to dive right in. So someone says, I find that a lot of my clients test me out to see how I will respond to their worst trauma by blurting it out right away. Is this something you've experienced or could unpack further? I feel like it might relate to containment.
100%. It relates to containment. Exactly the kind of thing I'm talking about in this webinar. And if you want more details, like really thoroughly unpacking this, obviously, you'll be able to find it in the book in chapter 4. But yes, absolutely. Testing is the operative word there. Yes, clients are testing. Why do people need to test? If we take an empathic stance, we can understand it well. People need to test because they truly don't know who you are and whether you will be capable. They don't know. They actually, if you think about it this way, they kind of should test. They really should, because they've been met with so much lousy response in response to their trauma disclosures that they actually really should test the waters. And so when clients test you, they want to know, can you handle it? Are you actually going to be empathic? Are you going to get it? Or are you going to be overwhelmed by the trauma? And so, yeah, so the testing is there. It's part of the relationship. So.
Okay, this one I think is super relevant because a lot of social workers might work in other environments that aren't directly supposed to be treating trauma. So she asks, how might a worker contain trauma in order to refer the client to another service that does provide trauma therapy? As a worker in mental health, I have clients open up in my first session, and I struggle with asking them or leading them towards other more fitting services that offer the right fit.
Yeah, so then you would really focus on the honoring the telling. That's what you would really focus on. You help them early on shift from, like in terms of your question, they start to tell you the story as soon as they come up for air. And I know that can be hard when someone's talking. So your skills around thoughtfully interrupting, again, I know it's tricky, it's hard to do. You see people, good journalists will do this all the time. They will have to find clever and socially appropriate ways to interrupt somebody and shift things. So that's part of good interviewing skill. So I would suggest really working on that, which is with trauma survivors. If you're working with a lot of people who need to be referred out, fairly quickly saying, Joe, as I hear you talking, it sounds like that's really been, your XYZ issue, the domestic violence you experienced with your partner, Dave. It sounds like that's been really hard for you, and you're really struggling now in relationships. I'm thinking, as we talked about, this is a short-term service, 1 or 2 sessions. I'm thinking that this might be the kind of thing that you're going to really need to unpack in detail with a good therapist who can sit with you and can hear you around all the ins and outs of how scary that was. Between you and me now, let me ask you, is this the first time you've talked about this, or is this something you've actually talked about with anybody? So I might say it that way. And so again, we're shifting toward the telling of the story. Or I might say, when was the first time you've ever talked about that? Or how are you feeling having told me about this? Because sometimes people have a hard time talking about these things. So again, you're shifting toward the telling of the story. I would do that. And then, of course, you're focusing on, what they're going to need in the next service, that sort of thing. So I would shift it toward that. Next question.
This one I think is related, and it's a really tough one. So it's a group of people, and they say, we work in the field of child protection. when we're working with a child in an investigative manner on cases of physical and sexual abuse, we are expecting and wanting the child to blurt it out. How does this fit with trauma and the struggle to open up?
Well, when you say blurts, I think that's the piece that we want to really think about. You're doing a different kind of thing than I'm primarily referring to in this book, and in this workshop, where I'm mostly talking about counseling and psychotherapy. When you're doing an investigation, it's extremely important, of course, and I wouldn't minimize the critical importance of an investigation, but an investigation is a different kind of intervention than a counseling or psychotherapy or even assessment for therapy. So I'm primarily a therapist. I study trauma treatment. That is different than an investigation. And I would say the ethics around an investigation and the techniques around investigation have to be different than the ethics and the techniques around psychotherapy. You have different needs. And when you're doing an investigation, there are issues of making sure that the child is protected and that somebody who's a perpetrator is actually brought to justice. That's a very different issue than when you're talking about psychotherapy. So the one thing I would say, though, is that you still don't want to leave somebody hanging. So if you're doing an investigation and the goal there is to help the person blurt it out, then what kind of allied services are you going to provide very quickly for the child so that they have a space with somebody to be able to deal with what they've just, done, where they're so vulnerable feeling now? So that's what I would make sure about there. So, okay. Next question.
Great answer. So this is a question about bringing the topic back into the room. What do you do if the client does not want to revisit the topic after weeks and weeks have gone by?
Right. Well, you don't force it. If the client doesn't want to revisit the topic, then I focus on that in particular detail in trauma and the avoidant client. So I talk about that particularly there. Where somebody has a trauma history and they're showing a lot of what in psychodynamic terms has been referred to as resistance. Of course, we don't want to think of resistance in a pejorative way. I only think of it as a coping strategy when clients are avoidant or resistant, if you will. I think of it as it's what people need to do to cope. I'm not thinking of it in a judgmental way. I think people do sometimes need to hold feelings at bay because it's what they've done to survive. And sometimes when I'm working with clients like that, I will even say, it's so interesting, Carrie, as we talk, I noticed in the first session we talked about this, and then in the third session you mentioned how upset you were at your mom and how her new boyfriend and domestic violence issues, and it reminded you of the domestic violence you went through. And now here we are about 3 or 4 months into therapy, and I've asked you a couple of times about the domestic violence, and I know you're kind of saying, I don't want to talk about this. And that's okay. I'm not saying you need to. I'm wondering if you have some thoughts about what might be going on. Help me understand all the reasons that you're feeling you really don't want to talk about it. So there, I'm bringing it into the room, but I'm curious about the resistance, and I'm giving it space. I'm unpacking it with them, not in a judgmental way, not in a way that says you're failing as a client. Instead, it's in a curious way. It's in a way that's respectful. That's how I would approach a client like that.
Rob, it is 1:59, but do you have time to take one more?
I have all the time in the world.
Okay. Let's take one more though. I'm mindful of audience members' time too, but this is a good one, and I don't think we've addressed it. Do you find you have to take a different approach to treating those that have experienced the effects of an acute trauma, say one horrific incident, versus someone that's experienced an ongoing repetitive trauma?
Yes. So there is an important diagnostic distinction between PTSD and complex PTSD, and I think that's where we really see what you're describing there. With more typically with the sort of classic type 1 trauma, like, a horrible thing happened, the person can actually remember. They can say, they could say, things were going okay until that rape that happened 3 years ago. And such happened, and it happened on this day. And other clients, you might ask them, so tell me about, I'll just keep on with the domestic violence, and the person might say, well, I don't even know where to begin. It was 10 years of it. I mean, I don't think 3 weeks went by without, I can't remember if that was the time that he beat me up when we were in Sault Ste. Marie, or that was the time when we went to his brother's wedding, or if it was that time when a week before my daughter was born. I don't even remember. It's just, it's all mushed together. It's all, that kind of thing. There's so many incidents. And so very often you see a kind of complex PTSD where the person has more profound and enduring effects on their self-esteem and their identity and their interpersonal, their ability to trust and that sort of thing in complex PTSD. Not to minimize PTSD, because the flashbacks, the memory intrusions, all of those can be debilitating as well. So there is a bit of a distinction. There are some good books distinguishing, looking up, focusing more on PTSD versus complex PTSD, but that would be the distinction. My book, Trauma and the Struggle to Open Up, does talk about both. So I would encourage you to take a look at that. And there's some other really good books. I'm trying to think who would I recommend. Let's see. I really like James Chu's book, Rebuilding Shattered Lives. That's another good book that I would recommend. So, but I think I'll leave it there with respect to that question. Again, feel free to contact me. You'll see my contact information is there, and my book titles. I'm on slide number 26 here. My book titles are there, which you can easily get. So there you go. If there are any other questions, do we have some time, or are we done for today, do you think?
Unfortunately, the time limit is now on my side, but okay. We're getting tons of thanks in now, and I just chose one to read to you. And she says, this is not a question, but a comment. As a clinical social worker who has been working with and treating trauma for 20 plus years, thanks, Robert, for a succinct and thorough presentation. Thank you. So that's the kind of comments that we're getting from our members. And so thanks from them. Huge thanks from us at CASW for taking the time to do this for our members. I think it was fantastic. Definitely the turnout speaks to how much this is an issue that preoccupies social workers. So thank you for sharing your expertise. Thank you to the audience for your great questions and your great participation. And we'll see you at the next webinar.
Okay, great.